So welcome back to this Doc Talk, a discussion of screening, risk assessment, and a focus on active surveillance. So in this second segment, Dr. Eric Klein from the Cleveland Clinic is going to talk to us about risk assessment, what clinical, pathological, and biologic factors need to be considered in determining the risk of progression for patients with early stage prostate cancer. And this is certainly very important in planning treatment for that patient. So Eric, bring us up to date on this.
Okay, thanks, Jim. I'm really excited by all of this because we now are developing the biologic tools that can help predict what's going to happen to an individual patient and really practice precision medicine when it comes to prostate cancer. And by precision medicine, I mean making a management decision based on the specific molecular characteristics of a patient's cancer. And we are really there, at least at an initial phase. So my disclosures first, I've worked with Genomic Health in developing their test that's on the market now, but I've also been a consultant with several other companies that are in the same space. And no one at the Cleveland Clinic nor I has any financial interest in any of these. So I think we have seen, at least in my career over the last 30 years, since the introduction of PSA, this balance where it goes back and forth between the idea that we needed to treat everybody, that's what happened when PSA came along, to the preventive task force recommendation that we don't screen and now that we don't treat anybody at all. And in reality, I think here's where we want to be. The real goal is selective therapy. Just as we talked about selective screening, risk-based screening, we want to decide who needs treatment and who doesn't based on their age and health and life expectancy, what the biologic potential of the tumor is, and I'll talk about the new tools that we have available to assess that. And of course, patient and family desire, which will always influence decision making. So here's the challenge for deciding on whether or not a patient is a candidate for active surveillance. This is a typical cross-section of a radical prostatectomy specimen that contains multifocal tumor of different Gleason's grade. And typically what we think we see in the clinic is that the biopsy only samples the low-grade tumor. And so the two questions that arise that we need to answer clinically is how well does the Gleason's grade predict true biologic potential? And how accurately does the biopsy that only samples the low-grade tumor capture the biology of the whole prostate? And I would argue that our current tools using the NCCN very low, low, and intermediate risk criteria don't do that as well as they could. And here's the real challenge. Using those three clinical categories, we can only assign an average risk for biologic potential or biologic progression to each individual patient. But we know in reality that within each of these risk categories that there in fact is a spread of risk. And so two patients can both have low-risk disease, for example, based on biopsy criteria, the volume of the tumor, the grade of the tumor, the number of cores involved, PSA and PSA density and so forth. But in reality, there's a spread of biologic risk. And until now, we haven't been able to distinguish those patients. Really what we need is, across this spread of biologic risk, is to distinguish patients who have low biologic potential in the green dots from those who have more aggressive biologic potential in the red dots, even though in the clinic, sitting across from the patient at an exam table, that both of those patients look the same to us clinically. Let me divert here for a minute on how we might do better risk assessment. If we think about what we see in terms of pathology and who's at risk for progression and what we might want to know about a patient who we're considering putting on surveillance before he goes on surveillance. We know that if you look at large numbers of patients who have undergone radical prostatectomy, that there are really two things that predict their risk of progression. That's the presence of high-grade tumor, dominant or primary pattern 4 or higher, and disease outside the prostate, either microscopic extraprostatic extension, seminal vesicle invasion, or lymph node metastasis. And we call these adverse pathology at radical prostatectomy. How do we know that these are worrisome things? Well, my colleague to the right, Dr. Stephenson, published this great paper about 8 years ago that showed in a Nomogram-based approach that there are three predictors of the likelihood of having progressive disease after radical prostatectomy. One, of course, is PSA, and that's probably the most important one. But for patients who go on surveillance, that's not nearly as important as it is for all patients, because the average PSAs on patients who go on surveillance, at least in our cohort, is under about 7.5 or 8. So it loses some of its predictive power. So once you get beyond PSA, what are bad things to have in a radical prostatectomy specimen? Well, it's dominant pattern 4 disease or non-organ confined disease, extraprostatic extension, seminal vesicle invasion, or lymph node positivity. So there is a common sense observation here that I think we need to make, and that is this. If having dominant Gleason's pattern 4 tumor or disease outside the prostate are bad things to have after you've had a prostatectomy, that put you at increased risk of progression, you would not want to have those things in patients who choose surveillance. And the NCCN risk criteria, very low, low, and intermediate risk disease, don't really do as good a job as biologic risk predictors, and we'll talk about these genomic tests, that actually can predict for those things better. And so we're moving into an era now where we take the risk categories, grade, stage, and PSA, which will always be important, and we're now adding biologic information to refine our prediction. So how well do the Epstein criteria, which is NCCN very low risk disease or low risk disease, predict for the absence of these adverse pathologic features? Well, if you look at the column labeled very low risk, it turns out that 1 in 5 patients who meet very low risk criteria actually have 1 or more of these adverse features, either higher grade cancer or non-organ confined disease, 1 in 5. What that means is that if we take a very low risk patient and put them on surveillance, 1 in 5 of those patients probably are not the best candidates for surveillance. And until now, we haven't had the tools to identify them. Even for low risk disease, actually, the situation is a little worse. About 30% of patients have either dominant pattern 4 disease or non-organ confined disease. Clearly, we can and should do better. Now, what available genomic markers are on the market to help us? Well, there is the genomic health test, the Oncotype DX prostate test, which I helped develop and will share some data with you only because I have the most experience with that. Metamark will be on the market soon with a similar test called ProMark, and Myriad's been on the market with a test called Polaris for several years now. All of these are biopsy-based predictors for worrisome pathology. And the question that comes up very early is, which is the best test? And the answer is we don't really know because there haven't been head-to-head studies on there. So for the purpose of my talk, I'm going to consider these as generic genomic markers, although what I'm going to show you is data from our studies with genomic health. But please consider them interchangeable for the purposes of this talk. So as I showed with the prior cross-section of a prostatectomy specimen, the challenge is, how well does sampling a low-grade tumor really tell you whether or not there's high-grade tumor or other worrisome features in the prostate? In order to get around that, when we developed the genomic health test, we microdissected low and high-grade tumors out of 500 radical prostatectomy specimens. And we assayed certain genes individually in the low and high-grade tumor and asked the question, was there a subset of genes that when measured in the low-grade tumor could predict for the presence of high-grade tumor or extraprostatic extension or non-organ confined disease, and how well did that match to what happened in the high-grade tumor? And not surprisingly, starting with a large number of genes, there were many that predicted those outcomes. But what was really surprising and encouraging was that there were a little under 300 genes in the bottom box there that predicted whether or not a patient lived or died after radical prostatectomy and whether or not they died of prostate cancer or got metastatic disease. And it didn't matter if you sampled those genes in the lowest grade tumor or the highest grade tumor. And that's really important. What it tells us is that for many tumors, probably not all, there's a common underlying biology, a pathway by which a low-grade or a high-grade tumor follows to become a tumor, and then they diverge. They have their own individual biologic characteristics. For example, the grade 4s make them individual. But in order to get there, they had to follow sort of the same tree trunk. And we can sample that on biopsy, as I'll show you later, in a way that's clinically useful. So the right-hand plot here shows the correlation between the predictive power, as measured by hazard ratio, for metastasis or death, for tumors that were sampled in the low-grade or the primary Gleason's pattern and the high-grade Gleason's pattern, and there's good concordance there, and the ones in red are the ones that are important. We also did some tests for whether or not these genetic markers predicted well in the face of multifocal tumors, and it turns out pretty well. Not as well as just looking at low and high-grade, but the concordance, again, for the tumors, or rather for the genes that are in red there, is still pretty good. So we have some confidence that using these markers can get past the problems that I showed on that cross-section of the prostate. One is the variability in Gleason's grade, and the other is in the multifocality of the tumor. So the idea is that we can now take a biopsy-based specimen that only shows low-grade tumor and predict the biology of the entire prostate, at least to a first approximation. And here's what they were able to predict. If you just look at patients who met AUA low-risk criteria, which is very similar to the Epstein criteria, or very low-risk disease, NCCN, you can see that using a score of these markers separated men so that most, in the blue or green, most who had a low recurrence score based on these genetic markers actually didn't have much risk of dying of their prostate cancer over the ensuing 20 years. But there was a subset of patients, low-risk patients, about 10% seen in the red line, that actually have a measurable about 10% risk of dying of prostate cancer over the initial 12 years after diagnosis. And I would submit that if you were 50 years old and you had a 10% risk based on a gene profile of dying of prostate cancer over the next 10 years, that you probably would not want to go on active surveillance. So I think this kind of thinking, these kind of genomic tests, can help identify the small subset of patients who have very low-grade tumors on biopsy that actually have real biologic potential, either because the tumors themselves, even though they're low-grade, actually have molecular characteristics of more aggressive tumors, or because the biopsy undersampled the presence of more aggressive elements. And also, interestingly, if you look at AUA intermediate risk disease, you again can see that most patients do progress. About more than half progress over a reasonable period of time. But there's a subset of patients in green who meet intermediate risk criteria, usually grade 7 disease, who actually have a pretty indolent course. And I would again submit that there's a subset of patients, perhaps older patients, who have intermediate risk disease who are being overtreated and probably could be offered surveillance. But again, based on NCCN clinical risk criteria, we can't tell who they are. Using these sorts of genomic tests, we may be able to do that. And the question that comes up frequently is how much additional value does doing an assessment of this biology by a genomic test, in this case gene expression, add to our usual clinical predictors? So this is a nomogram-based approach based on the Stephenson nomogram that I showed you that shows that the recurrence score, which is the output of the gene expression levels, adds more points than PSA, grade, or stage in predicting the likelihood of getting metastasis or death after radical prostatectomy. So 2 important points here. There's a lot of information in the biology that's not captured by grade, stage, and PSA, but it's additive to grade, stage, and PSA. So these tests won't be used in isolation. We will still need to use our usual clinical predictors that we're comfortable with. And these are the genes that are included in Genomic Health's Oncotype DX prostate. And there are 12 cancer-related genes across 4 different biologic pathways and 5 reference genes. And so just to emphasize, what do these genes predict for? Well, they predict for metastasis and death when measured in prostatectomy specimens. In work I haven't shown you, we did a separate study looking at whether or not these genes could predict for the things that we said we would not want in a patient who's going on active surveillance, and that's dominant pattern 4 disease or disease outside the prostate. And in a separate study, and one that's been validated, which I'll show you in a minute, the same genes that predict for metastasis and death in prostatectomy also predict for this surrogate endpoint of adverse pathology at radical prostatectomy. So now we have at least one genomic test, and presumably the others can do this also, although that's not been tested formally, where we can take biopsy material that biopsies only low-grade disease and tell what's happening in the entire prostate. And that's really what we need to know when we're sitting across the table from a patient trying to discuss trying to discuss surveillance with only grade, stage, and the biopsy characteristics present. So does this make sense biologically? This is sort of a startling observation that we're suggesting that you can predict progression based on a biopsy and low-grade tumor. And the answer is, I think, yes. Again, for most tumors, this isn't going to be perfectly accurate for all tumors. But if you look at the data that's been published on the mutational landscape in prostate cancer, you can see all the genes that are in green are commonly mutated in early stage and metastatic cancer. And there's a lot of other data in the literature at different genomic levels to suggest that there's usually a signal in the low-grade or early stage tumor that mirrors what's seen in the metastatic disease. So this actually has some support. And again, the idea is what I raised previously, is that if you sample the mutations in the trunk of the tree that both low and high-grade tumors have to go through to get to be a tumor, that you can sample this common underlying biology. a little bit startling. So the next thing we did was, once we were able to demonstrate that this genomic prostate score could predict outcome, either on biopsy or after radical prostatectomies, we went to Peter Carroll and Matt Cooperberg at the University of California, San Francisco, and we asked them to do a validation study. They took about 400 men who were candidates for surveillance and looked at their biopsies to see if expression of these 17 genes in biopsy material could predict for adverse pathology at radical prostatectomy. And what you can see here are the average risk for average pathology in the little colored dots for very low risk, and intermediate risk disease. And here you can see that the addition of genomic information really shows that within a given category, in this instance very low risk disease, there's quite a spread of biologic risk. And so if you were one of those two men, the little green dots way over on the right, and you're 50 years old and healthy and facing 30-year life expectancy, and the biology of your tumor, as measured in your low-grade cancer biopsy, show that you have only a 60% chance of having organ-confined low-grade cancer, you might not want to go on surveillance. And most everybody else probably could go on surveillance. We see the same kind of spread for low-risk disease, and we see the same kind of spread for intermediate-risk disease. And again, here, the useful information is to the left, and that is that there's a substantial population of men with intermediate-risk disease who generally get treated in the U.S. who actually probably could be followed. So that's how this information can be useful. At a very high level, here's how biologic risk discrimination would add to our clinical criteria. And again, this is true for any of the tests that are available on the market. So we generally assign patients to NCCN very low, or intermediate risk disease based on grade, stage, and PSA. We can add biologic information now, and we can see how the biologic information modifies the patient's risk of progression ultimately. If it confirms the hypothesis, or the example here is you start with a patient with low-risk disease. If the biologic information suggests very low-risk disease, that's a great candidate for surveillance in my view. If it simply confirms that the patient is in a low-risk category still, then you have to look at the detailed characteristics of the patient. A younger patient with a long life expectancy might or might not want to go on surveillance with low-risk biologic criteria. An older patient with low-risk biologic criteria is probably a good candidate for surveillance, or somebody with comorbidities. And then patients who start at low risk but ultimately get pushed to intermediate risk, and if they have a long life expectancy and are healthy, they're probably not good candidate for surveillance. We need more clinical experience with all of these tests to really validate this approach, but at a high level, this intellectually shows you how this kind of information could be incorporated into clinical decision making. So I'll close with a couple of cases from my own practice where I've found this information useful. A 53-year-old healthy white male with very low-risk characteristics. Here's his biopsy that shows just one core out of 12 with 20%, 1 millimeter of cancer. He meets the very low-risk criteria, and he was interested in surveillance. And I was a little uncomfortable with that because of his young age, but he meets the standard criteria now. So we did a genomic prostate score on him, and he actually stayed in the very low-risk category. So you can see he has an 88% chance of not having dominant pattern 4 disease or disease outside the prostate, and that validated his choice for active surveillance. And in most instances, about 80% of the time, this test in particular will validate the choice of active surveillance, and I think there's value in that. But here are two other cases, very similar age, similar PSAs and so forth, both of them healthy. The one on the left has low volume Gleason 6 disease, at least by cores, but 40 to 60% along each core are involved with cancer. And then the one on the right has less cancer volume. And when I show this to average urologists, they generally will say they want to treat the first patient and observe the second patient. These are both patients who have low-risk criteria, and based on that criterion, they don't look different to us. But look at their biologic potential. Patient A, who had the higher volume tumor on cores, 40 and 60%, actually moved from the low risk to the very low risk category, and is probably a good candidate for surveillance. Whereas patient B, who only had one core involved, biologically moves to the intermediate risk category, and I suggested that he be treated. So the first patient's been on surveillance, and he's had a negative biopsy at 1 year, and we're going to continue surveillance. The patient on the right, at my suggestion, had a radical prostatectomy, and indeed he had Gleason's 3+4 disease with focal extraprostatic extension. He's probably cured, but again, he's someone that I would argue that was not a good candidate for surveillance, given that that was his baseline pathology. Third case, this might be the most dramatic one I've seen, a 75-year-old man, PSA of 16, who was finally biopsied after having a high PSA, and you can see the other details there. And his biopsy shows a microfocus, less than a millimeter, of Gleason's pattern 3+4 disease. He's 75 years old. Because he has Gleason 7 disease, he's in the intermediate risk category, but I strongly recommended surveillance to him based on his relatively limited life expectancy because of his age and so forth. He insisted that he wanted to have better risk assessment, and so we went ahead and did the genomic prostate score on him, and look at this. He had a very low likelihood of having organ-confined disease. And so we went ahead and did a radical prostatectomy on him. He had Gleason's 8 disease. He had unifocal Gleason's 8 disease, and he had extraprostatic extension. So let's go back to the original biopsy and show you how powerful this information can be. It's not like this in every case. Less than a millimeter of Gleason's 3+4 disease, and here's his prostatectomy specimen showing Gleason 8 extraprostatic extension. There are patients who really are undersampled where a test like this, or alternatively, the growing interest in magnetic resonance scanning, which presumably would have seen this tumor, that tell us that this patient is not a good candidate for surveillance. And I would suggest that getting it right and intervening at the right time is the right thing. So Andrew's going to talk about active surveillance, but I just want to give you at a very high level the sort of the current paradigm and there are different flavors of doing this, and show you how genomics can add to this paradigm. So the current paradigm is initial biopsy and risk stratification, and making a decision about whether or not someone wants to be on surveillance based on their life expectancy and their choice. And then they get rebiopsied at some point, usually within, at least in our practice, 3 months or so, to be sure that they're not the 1 in 5 patients who meet the Epstein criteria who actually have higher grade tumor. And then they undergo periodic reassessment. And then if they progress to a different risk category, we get intervention. So how can genomics help this? Well, I think there are 4 ways. The first is that we could reduce the burden of determining eligibility of surveillance by substituting the performance of one of these genomic tests for a second biopsy. Why is that? Well, I think the genomic tests do a better job overcoming the sampling error that comes with biopsy. At least the genomic health test, I think, has been shown to do that, and the others probably could be shown to do that. And there's no risk involved there. So the second biopsy has the same sampling error as the first biopsy and has the same risk of infection and sepsis and so forth. Another way would be to improve patient selection for patients who actually go on surveillance. So if you have a patient who decides, regardless of their genomic score, to go on surveillance, if they have a favorable score, you could probably look at them a little bit less frequently, and if they have a higher score, then you'd want to reevaluate them periodically. And that's actually in the third bullet point there. And the last thing is that doing serial testing on multiple biopsies over time could help you decide when to pull the trigger. I think that's one of the problems that the case we're going to discuss later is going to show. So finally, let me just put this in perspective. I think we're on the threshold of a new genomic-based precision medicine paradigm for prostate cancer, particularly to help avoid overtreatment. These biomarkers add to, but don't replace, standard predictors of outcome. This is very important. This is new biologic information that adds to grade stage in PSA, and we never want to ignore those. There's a lot of information there. We also don't want to ignore patient choice and desire and comorbidities and so forth. I'd also say that these are first-generation assays. In my view, they do improve decision-making, although they're not perfect. There are, I know of cases already that are in press and that others have shared with me where the genomic markers haven't totally captured the biology of the prostate. But I believe that for a substantial number of average prostate cancers, they add more information and they make us better decision makers. And as the technology advances and the scope of genomics improves or increases, we'll get better at this. And finally, this is important, people wonder about cost. It's true in everything that we do that getting a clinical decision right the first time is always the most cost-effective approach, and I think that justifies using these particular tests. So as I said at the beginning, I'm really excited about being in this era of prostate cancer, and I think you can understand why now.
All right, Eric, thank you so much. I just have a couple questions. Between the different tests, the Oncotype DX and the ProMark and the Prolaris, is there many genes in common? Or I know in breast cancer, the gene panels are very different.
Yeah, the gene panels are different also. The Polaris test is based on 22 genes, I think 24 genes in the same biologic pathway, proliferation. The Genomic Health and the Metamark test cross different biologic pathways. The important point is here that genes of all sorts can predict outcome, and we're not saying for any given test that those are the only genes that are important, just that those particular genes in that test have been shown to be clinically useful.
In your practice, are you submitting these tests in almost everyone who has either very low, or intermediate?
I use them in any patient who is interested in active surveillance across all the clinical scenarios, all the comorbidities and that sort of thing. I recommend it as a routine part of the evaluation, because I believe if you look at the nomogram-based approaches and the decision analytics that have been published on these tests, that while they're not perfect and maybe far from it, they do allow us to make better and more accurate decisions for more patients than we do just based on grade stage and PSA.
And what is the turnaround time typically?
Yeah, 2 to 4 weeks.
2 to 4 weeks,
Yes.
Okay, very good. All right, any comments, Jerry or Andrew?
No, I think we are on the cusp of a new era in prostate cancer care. I think that genetic tests like this will personalize the care that we give, and it's much better than relying on a light microscope that was invented about 500 years ago.
Yes.
And secondly, the other thing I think is going to change a lot, and I know Andrew's going to talk about it, is better biopsies. The biopsies we do are pretty random and unpredictable sometimes. But if we could do targeted biopsies to the most suspicious or abnormal parts of the prostate, the biopsies will get better. Couple that with better genetic prognostication, and you know what? We could do a much better job.
Very good. Well, we'll stop here, and we'll be back in just a minute, and we'll have Dr. Andrew Stephenson talk about the role of active surveillance and when to recommend it and when to move forward with immediate treatment.